From the classroom to the emergency room, OR, and beyond, you're joining Trauma ICU Rounds with your host, Dr. Dennis Kim.
So one of the best pieces of advice, it was from Dr. Rosen, hernia specialist, Cleveland Clinic. He said, find something nobody else likes, it's not sexy, and own it. And the other thing was, where it actually came from my interest was I had a patient when I was a chief resident I was convinced was fine. He had bowel obstruction, put him on medicine because why would you want to make your own chief service even busier? And 12 hours later, we were getting calls that the guy wasn't doing well. He had a strangulated bowel obstruction that I completely missed. That really drove me like, what did I miss and how can I do better? And what can we make sure that this never happens again? So that's really where it all started for me.
That's Dr. Martin Zielinski sharing his thoughts on how and why he decided to pursue bowel obstruction as a major area of research focus. Dr. Zielinski is a professor of surgery at the Mayo Clinic College of Medicine and Science, where he also completed his residency and fellowship training. Interestingly, prior to medical school, Martin was voted captain of the 1998 to 1999 NCAA swimming team, and he qualified not once, but twice to the swimming Olympic trials, both in 1996 and 2000. Interestingly, 2000 was the year that a young 15-year-old by the name of Michael Phelps also qualified for the 2000 Olympics. Faced with a choice between med school and the pursuit of Olympic glory, Dr. Zielinski conveyed to me that he's happy with his career decision. As with so many of our guest professors on Rounds, Martin is involved and has made significant contributions to our major surgical societies, including EAST and the AAST. He's authored over 155 peer-reviewed articles, a dozen or so textbook chapters, and has really done a great job advancing our knowledge in the management of several key trauma and emergency general surgery topics, including hemostatic and damage control resuscitation, management of the open abdomen, and the topic of today's rounds, which is bowel obstruction. So, Dr. Zielinski, thanks for joining us on Rounds. For those of us familiar with you and your research as well as academic interests, it's quite apparent that bowel obstruction is a topic of particular interest to you. And this is certainly one of those bread and butter general or acute care surgery topics that we encounter pretty much on a daily basis. In fact, I can't think of a single call ever where we haven't received at least one consult for either a patient with a bowel obstruction, suspected bowel obstruction, or simply dilated bowel on a CT scan. So why is this such a common problem? And why is bowel obstruction a clinical condition that students, residents, and fellows alike need to be familiar with and comfortable managing?
Well, we do thousands of laparotomies and laparoscopies in the country every year. So every single incision that we make on the abdomen increases the risk that we're going to have small bowel obstruction patients, or at least patients at risk for small bowel obstruction, which is where you get a lot of those other consults from you were mentioning. So anytime you're in the peritoneal cavity, you're at risk for adhesions. So it's going to be something that you're going to see very commonly given the amount of operations that we do.
And when you think about the etiologies for bowel obstruction, and we already mentioned adhesions, which are certainly one of the most common causes, especially in patients who have undergone surgery, what about patients with a so-called virgin abdomen coming in with clinical signs and symptoms of a bowel obstruction? What's your approach or differential in these patients?
Yeah, so the management of virgin small bowel obstructions really has been changing over the last couple of years. The paradigm has been virgin abdomens shouldn't be having adhesive disease because they haven't had an operation. And actually, we're learning exactly the opposite. And I think that's a combination of the recognition of that, as well as improvement in the CT scan imaging techniques that we've had over the last 5 to 10 years. So in the old days, 10 years ago plus, let's say, the standard, I think, was still virgin abdomen means exploration. And the reason for that is, and traditionally taught is, well, what if there is a malignancy causing that? And there's probably a thought that there might be a little bit higher risk of failure of non-operative management. And so that the laparoscopy, I think, became the standard of care in those patients, at least over the last 10 years since laparoscopy became, a much more common thing. Even before that, laparotomy was indicated in a lot of surgeons' minds. Now, over the last several years, in a couple of publications on this, it turns out that adhesive disease in virgin abdomens is actually quite extensive, and up to 40 to 50% of these patients will have adhesive disease. And it could be from a history of diverticulitis or gastroenteritis that was never diagnosed or really, worked up, or, patient may remember it as a severe thing that allowed them to get through the episode without an operation, of course, but have adhesions and scar tissue that form. So that's, I think, why it's so common. Now, why is it that we're now changing that paradigm? And I think it's the recognition of that. Our CT scan images, if you don't see a mass, there's probably not going to be a cause. Is that 100% of the case? No. We had a paper coming out about a year or two ago, actually fighting against that very thing, that out of the patients that we saw, I think it was like 4% of our patients actually had an undiagnosed malignancy or lesion, let's say, not on CT scan imaging. And so we actually changed our protocol here and put it out there in the public domain in the paper. We now don't routinely operate on virgin abdomens unless there's something on the CT that we're concerned about. And that includes strangulation or malignancy. And then if we don't operate on that patient, we actually recommend colonoscopy and CT scan reimaging, usually CT enterography, just to define that a little bit better. Because it turned out on the patients that we missed, there were very subtle findings on the CT that we would have picked up if we would have looked a little bit harder.
Agreed. I definitely see the paradigm evolving. And I know that when I've taken patients with a virgin abdomen and suspected bowel obstruction to the OR, we typically start with the camera or the laparoscope. And when you find nothing, it's such a frustrating kind of feeling. And then you're in this awkward position. Well, can I really rely on the chopsticks and the camera, or do I actually need to run the bowel with my hands and feel for a potential mass? And the last two patients that I did this on, it came back completely negative. So I do like the idea of following up in 4 to 6 weeks with repeat imaging, and depending on their age and other risk factors, follow up with the colonoscopy just to rule out an occult GI malignancy.
I think you bring up an excellent point, that of laparoscopy not giving you that real tactile feedback for some of those more subtle findings that you might see in the operating room. Any type of small malignancy, it could cause it, whether it's a GIST or something else. Little neuroendocrine things, they can cause intussusception. They can cause a little bit of torsion. They can cause just a frank blockage of the lumen of the small bowel, and you may not be able to see and or feel it when you're using those instruments. So sometimes you do a negative laparoscopic exploration, and you're like, "Ooh, are you sure we didn't miss something?" And you want to open up, and so that's that surgical momentum that drives us. And I don't know that we have data on that specifically, but I bet you a lot of those are still negative open explorations.
Yeah, and that's certainly been my personal experience to date. Now, I like how you brought up the concept of luminal versus extraluminal and intraluminal etiology. Certainly when I talk with students about bowel obstructions, that's one of the ways that we can anatomically think about the causes or etiologies, with intraluminal causes being the least common, things like phytobezoars or a gallstone ileus, which we all see once in a while. The luminal causes, like you mentioned, would include malignancy, strictures, inflammatory processes. And then you also mentioned diverticulitis, and we've certainly seen our fair share of patients where their small bowel gets all wrapped up in that inflammatory mass in the left lower quadrant, and then they end up presenting with a high-grade bowel obstruction. Now, one of the things that I've noticed at our morning pass-ons or rounds is that when we talk about bowel obstructions, it's presented as kind of like this vague term or diagnosis. Maybe it's just me being old, but I remember when we used to use KUBs to make this diagnosis, I feel like we were using better descriptors. This is a high-grade distal mechanical small bowel obstruction, and the etiologies include A, B, or C. But like you mentioned, with the improvements in CT technology and resolution, we get so much valuable information just looking at scans.
So if I can comment on that, and actually I don't really like the term high grade, low grade, because the implication there is high grade means go to the OR, low grade means non-operative management. So that's actually not really how it was originally meant to be. High grade was really a discrete transition point, usually see on KUB, prior to the initiation of CT. And that meant you go to the OR, and that doesn't necessarily translate to CT scan imaging. So the high grade, low grade dichotomy, I think, is actually old-fashioned. I actually prefer operative versus non-operative, and that's where a lot of that predictive models really comes from. And the other thing to mention, I think, there's not as, you say not as much description as far as high grade, low grade, and some of the other terms. But what you do is have a picture in front of you. And, with technology now, we're rounding with those CTs in front of us. Everybody can get a look at that. And so now you describe mesenteric edema, you describe small bowel fecalization, you describe a swirling of the mesentery, pneumatosis, rather than high grade, low grade, and some of these other kind of older terms.
Yeah, Dr. Zielinski, I think that's a really important point that you're making. For the learners out there, when it comes to bowel obstructions, one of the first questions you do want to ask yourselves outside of is your patient stable or unstable is really, is this bowel obstruction operative versus non-operative? When you talk about models and predicting failure of non-operative management, you mentioned quite a few findings on CT, including mesenteric edema. Now, another common finding, or maybe not so common, but we do see on a regular basis, is fecalization of the small bowel. Is that reassuring or not reassuring?
Yeah, this gets confusing, and we talk about it almost weekly, monthly with the residents, because small bowel fecalization is an abnormal finding, but it is a beneficial finding in the setting of small bowel obstruction. I don't know exactly why, but a working theory is that the bowel obstruction had been going on for a period of time long enough where fecalization can actually happen. The microbes are creating stool because of that stasis. And that stasis implies that it's not an emergent twist or strangulation that you need to rush off to the operating room. So I think that's why it's really confusing. It's abnormal, but it's beneficial.
And then what are the other key findings that we should be paying attention to? So we get a patient they're distended, they're coming in, they've had a previous operation, and they've got some nausea, vomiting. You get the CT scan. And what other kind of findings should we be paying attention to that might increase our concern that this patient is going to fail non-operative management?
So the first thing you want to do is rule out strangulation. And that could be on history and physical. I think the acute onset of abdominal pain where somebody can tell you woke them up or at 2 a.m., that's where the pain started. That's a concerning finding on history. On physical exam, of course, you're going to be looking for peritoneal irritation, rebound tenderness, those kinds of things. But don't forget about hernias, femoral, inguinal, ventral. Obesity can, of course, hide a lot of those as well. But then again, little old ladies with their femoral hernias look below the inguinal ligament. But on CT scan, which is really where your question was coming from, again, there are signs of strangulation, pneumatosis intestinalis, portal venous gas being two of the more common ones. If you gave IV contrast, you can look for poor perfusion. Sometimes you'll see the reperfusion as well, and it'll be actually hyperemic. And we can talk about that, but that's a concerning finding, but hopefully a beneficial finding. But really, we came up with a predictive model about 9 or 10 years ago now, trying to find out who should be in the operating room within hours of admission. And the findings that we found over a couple of different papers, but the bottom line is small bowel fecalization. It's lack in the setting of small bowel fecalization, or in the setting of small bowel obstruction, and then in conjunction with mesenteric edema and obstipation of 24 hours or more, those three findings are actually very concerning and actually more predictive than most of the strangulation findings on physical exam, and labs like white blood cell count elevation, things like that. And so when you had that, about a third of the patients actually had strangulation, and about 90% of them underwent an operation during that hospital stay.
Great. So to summarize, for patients with bowel obstruction, first rule out strangulation, and a solid history and physical exam are critical there. Be vigilant for the presence of hernias. For patients who undergo a contrast-enhanced CT, look for things like pneumatosis intestinalis, portal venous gas, or hyperemia, which may be associated with reperfusion injury. But really, when it comes to the potential presence of strangulation and a high index of suspicion for the need for surgery, lack of small bowel fecalization, together with the presence of mesenteric edema and obstipation of greater than 24 hours or more, should get us concerned that this patient is going to require an operation. So Martin, just to get back to the differential or etiologies for bowel obstruction, what are some of your key pearls and pitfalls when it comes to the initial recognition of a patient with a bowel obstruction?
So I think the main thing to hammer home is the top causes of small bowel obstruction, the etiologies, of course, adhesive disease that we've talked about. Hernias, we've talked about a little bit, but don't underestimate some of the stranger hernias or the ones you might not expect. Inguinal and femoral being most common because we don't tend to look down there on physical exam. And again, obesity can hide a lot of our exam, of course. It's hard to know when obese people have an incarcerated hernia, and so that or even strangulated. So that's an important part of the exam to try to see if it's even reducible or try to reduce it. But then, tumors, most of the time people will have a history of malignancy, but not necessarily. And those are the ones you really worry about. And it gets back to some of the virgin abdomen discussion we had a little bit earlier. And then, of course, there are the strange ones, Crohn's disease being, number 4, which generally speaking is managed medically. Not always, but managed medically for the most part, unless it's kind of a more chronic indolent disease. And then you get a whole host of weird things, the phytobezoars, some worms, so if you can't figure it out, take a history. I've had a person come back from Asia with worms in their roux limb, believe it or not. That was wild.
Well, certainly common things being common. We've mentioned adhesions and hernias. I think one of the easy mnemonics that I learned during medical school is shaving. And that stands for S strictures, H hernias, A adhesions, V volvulus, I intussusception, N neoplasm, and G gallstone ileus.
Oh, sure.
That's always a simple way that I've thought about different etiologies for bowel obstruction, whether it's small bowel or large bowel.
The intussusception one is an interesting one we can talk about a little bit too.
You got to operate, right?
Well, no. And that's an interesting question. I think that's an evolution too.
Absolutely.
Again, mantra was intussusception, abdominal pain. You probably need to do an operation because it could be strangulated or there could be a lead point. Turns out, especially in the era of gastric bypass and Roux-en-Y's, for whatever reason, and I don't know that anybody truly knows, Roux-en-Y gastric bypass patients, maybe they lose weight and their mesentery becomes hyperdynamic, if you will, but or floppy, but they will get intussusceptions, and we actually do not operate on them unless they have hard signs of strangulation. So we'll sit and watch those folks. And then you'll get the people that intussuscept on a monthly basis, and then you never know what to do with that. And we've gotten burned a lot by those. We operate, and then we'll operate again. We're like, well, no. So I think that management's changing. I don't have all the answers there, but...
Yeah. We see it not infrequently, pretty much as an incidentaloma. Like we mentioned earlier, our CT scan resolution has improved incredibly, such that if the bowel is imaged at just the right angle and there's a bit of a peristalsis going on, you see a radiographic intussusception, and there may not be an associated lead point polyp or mass, and oftentimes you can get away with non-operative management. Again, I think the idea of a delayed or outpatient workup in 4 to 6 weeks is probably in order.
Yeah, CT enterography usually. Colonoscopy maybe. Yep.
Absolutely, yeah, depending on the patient's age and potentially their comorbidities. So patient comes in, we're concerned about bowel obstruction. Oftentimes we get called once the CT scan is done, and I'm not sure how it works at your shop. I'm pretty positive I have a good sense as to how you're doing it at the Mayo. But here, oftentimes there's no oral contrast. It's just CT with IV. And that goes across the board, even in patients in whom there's an obvious history of previous abdominal surgery. They're not routinely getting the gastrografin swallow in there. So maybe we can talk a little bit about that, because you've done quite a bit of work when it comes to the gastrografin challenge.
So I think the initial question is, should you have oral contrast on the CT scan? And I don't personally think it's necessary. And actually, most commonly, it's not performed. And there are a couple of reasons for that. One is the patient's vomiting, probably distended. Hopefully an NG tube was placed, but not necessarily. Definitely don't want to give that patient gastrografin if they're vomiting, given the risk of aspiration, of course. So that's a hard stop, generally speaking. If they make it past that step, sometimes they will, but in most emergency departments, they don't want to wait the time that's required for the oral contrast. They just want to get an answer, and so they'll send them off without oral contrast. So I think that explains a lot of that. Now, there will be the occasional patient that does get it, and then they'll have a bowel movement just because of that small dose of gastrografin, and that's actually quite telling, I think, because they had a mini gastrografin challenge.
And so what is it about the gastrografin in patients in whom we're suspecting adhesive bowel obstruction or small bowel obstruction? How does it work, and what sort of information does that give us?
So we have a pretty rigid protocol for us here, and it's, number one, you need to decompress the stomach for several hours. We say 2 hours. And that's extraordinarily important because gastrografin pneumonitis is a deadly disease. It can cause ARDS. And if somebody is to aspirate because of lack of decompression, then you might be in a whole host of trouble. And the patient definitely is going to be. So that's number one. The next step, I'm assuming you've already undergone CT and you got your diagnosis. But the next step, and you don't have signs of strangulation. But after that, it's infuse the gastrografin. We do 8 hours just based on the meta-analyses that show there's no additional benefit waiting longer. Mm-hmm. And the other advantage of waiting 8 hours, we actually have a gastrografin protocol for our ED OBS unit. And what that allows us to do is get patients to the ED OBS unit, get the gastrografin challenge, advance their diet if they pass, and then out of the ER and never get admitted within 24 hours.
Very nice.
So that's been actually quite a benefit. We reduced admissions by about a third, which is pretty big from that standpoint. So if the patient has a bowel movement, or if they don't have a colon, or they have an ileostomy or something, has stool coming out of their stoma, then we consider that a passed challenge. The other way of passing a challenge is X-ray KUB with colonic contrast, because that implies that the contrast has made it past the small bowel transition point.
Yeah.
And if that's the case, we'll remove the NG tube and advance their diet and diet challenge, and hopefully they'll go home thereafter.
And in terms of the gastrografin that's being administered, is this a nurse-driven protocol, or is this something the CT techs or you guys are doing as physicians?
It's actually a nurse-driven protocol. Of course, we'll sign the orders, but we have a full order set that empowers the nurses to do the timing of the decompression, to initiate the oral contrast without an extra order, and then to order the X-ray as part of all of that. It actually gets ordered on our medical record system. And then they are able to then read the report of the X-ray and then call the service to confirm. We don't, independently let it do, because there are some subtle things about all that, but we will have them call the service at that point, say, hey, they passed the gastrografin challenge or they didn't, and then what are the next steps?
And then in terms of the timing of the KUB or the repeat imaging, you're looking for this gastrografin to hit the colon. And so is that at the 6-hour mark, 12 hours, 24 hours? By what time period should we be seeing that transition?
We do 8 hours. That is up for debate, I freely admit. There's just not enough data, and you lose power based on the meta-analyses that are out there. But the best meta-analysis out there is actually showing that if you wait longer than 12 hours, or longer than 8 hours, there's no additional benefit. Now, whether if that's a statistical anomaly or truly accurate, we can debate that, but that's the current thing. We are looking at, actually, we partnered up with a different institution that does 24 hours. Actually, they do like serial X-rays throughout all that. And some of that preliminary data actually shows a little bit even shorter time frame, maybe even 4 hours.
And so the thing with the gastrografin is it gives us prognostic information in terms of patients who can be managed without an operation. It also helps, I guess, in terms of diagnosis if the CT scan hasn't given you that information already. And then it's also therapeutic. And how is it therapeutic? What is it about the gastrografin that helps so much?
Yeah, so I think it is therapeutic. We can debate this. Our data and multi-center trial we did through East definitely showed a therapeutic benefit. Now, there are randomized controlled trials out there, and the most recent one from Europe did not demonstrate a therapeutic benefit. So you can debate that. But the current thinking is, and nobody really truly knows, but the hyperosmotic effect of gastrografin draws edema into the lumen, and then therefore allows the edema of the bowel wall to soften up, and then hopefully allow contents to pass through. Functions sort of as a laxative as well. Having said that, there is some data that non-hyperosmolar oral contrast agents, urografin and things like that, have similar therapeutic effects.
So we've got our patient and, the gastrografin's not going through. We're waiting. It's been 6, 12, 24 hours and still no resolution with ongoing distension as well as high NG tube outputs. So when you're thinking about going to the operating room, are you uniformly thinking start with the camera, or are there situations where you're just going to jump right into an open laparotomy?
Yeah, that's a patient-specific decision.
Absolutely.
So, of course, if we think it's feasible, just like a lap chole, if we think it's feasible to do a laparoscopic explore, we'll try it, because you can run the bowel pretty effectively, as we're well aware. The problems become is significant abdominal distension, like you described. You may not have a window in the peritoneal cavity to actually be able to do what you need to do. And so visualization of the critical structures obviously is a necessary part of that operation. The other issue behind all of that is adhesions. I'm okay laparoscopically. I'm not great, but, we can lyse some adhesions here and there. But when you get really tight adhesions, I get very nervous, and so I won't do that. So I'll open at that point if there's something that we need to do. And then, of course, the other thing to consider is if you can't fully explore the abdomen for whatever other reason. And then, we convert to open pretty quickly if there's strangulation, if there's a mass, if there's something else we can't do. And so I can't remember the exact number, but I would guess we probably are on the order of 30-40% of our explorations are probably done successfully laparoscopic. So quite a number are still.
When it comes to things like port placement, how do you think about entry? Are you using a varus, or if someone's really distended, are you more apt to go with open Hassan approach, or does it change at all?
I am not a varus fan. I do an open Hassan. Now, that incision can be dictated by the prior operations. People have mesh from prior hernia repairs. Those kinds of things need to be taken into consideration. By and large, I will do supra or infraumbilical linear incision for a Hassan technique, if otherwise indicated. If there's mesh in the plate, in the belly, that gets to be tricky. We'll usually go in the right or left upper quadrant. Sometimes we'll use an OptiView in the left upper quadrant. Sometimes we'll do a cut down. Those are kind of the approaches. But as you're saying, it's an individualized decision, and you need to really look at that CAT scan. Because the other thing the CAT scan can show you is adhesive disease where there's just no plane between the bowel and the abdominal wall. So that's another critical area of that.
Yeah, I always pay attention to that when I'm looking at scans and look at them in all three planes. It gives you a roadmap, and why would we not use that information outside of just saying they've got a bowel obstruction? So certainly will help with your approach. And I think the point that you made about patient specific, that's absolutely right. Some patients are going to have a simple little adhesion in the right lower quadrant from a previous open appy, and those are the ideal candidates for using the laparoscopic approach. Now, before surgery, we're always going to want to drop an NG tube. And this is one of those things that I kind of find sometimes gets missed. I mean, we see patients, they come in, they're distended, they're vomiting. You ask, what are their NG tube outputs? And, the order's been put in. I'm not sure if the nurses have dropped it yet. I always thought that this was something that we should be doing. That's like the therapy, suck and drip. Right? You want to suck out their enteral contents or gastric contents, and then you want to be dripping in some IV fluids to replete them. Thoughts on that?
Yeah, in my mind, I got a couple of thoughts. In my mind, that's the emergency department's first job. Besides fluid resuscitation, should be their first job, is to drop an NG tube. Now, having said that, there are patients that will refuse because it's uncomfortable, and then there are providers who are like, oh, I don't want to make them uncomfortable because it stinks, right? Who wants something shoved up their nose? But by and large, people actually feel a lot better after that decompression. And the other thing to really think about is the people that you have inserted NG tube and they are not better after decompressing. Those are the ones you really need to be worried about, because it may be more than just a visceral stretching problem going on. They may have some other issue, strangulation or something.
And so, how long do you normally give a patient? Let's say they've had multiple previous operations. We know they've got an adhesive bowel obstruction. they're now day 1 or day 2, and they're still having, relatively high NG tube outputs. What's going to be the final trigger to kind of convince you that this patient needs operative intervention, and how long would you wait?
So if they pass the Gastrografin challenge, 90% of people will not require an operation based on our data and multi-institutional data as well. If you're in the 10% of patients that passed but aren't passing the diet challenge now, we give 3 to 5 days. That's a very vague term, but the reason why it's 3 to 5 is most of those patients don't need to go operatively on a Saturday or Sunday, and some of those cases can be really complicated. And if you're on trauma call or other emergencies are coming in, you don't want to be stuck in a 3-4 hour case lysing adhesions all afternoon. So that is something I think you really need to take in consideration. What else is going on in your world? You can operate on a Saturday and Sunday, and we will do it. But a lot of institutions, you're probably the only one in that hospital at that point that can respond to some of these other things. So I think that needs to be taken into account. So 3 to 5 days. And of course, serial physical exams, if there's a worsening exam, that would prompt strong consideration for exploration as well.
Do you use any biomarkers? Is lactate going to be helpful at all? We've looked at things like hyponatremia and the presence of that kind of suggesting the presence of badness, whether that's ischemia or a strangulated hernia. Thoughts on that?
Yeah, so there are a couple biomarkers that I've read about in the literature. Lactate, of course, being a prime example. If the lactate doesn't resuscitate, that's a concerning finding. An elevated lactate more than 5 or so, I don't have any strong data on that, but that would get my attention. Mm-hmm. Most people will have a 3, 2.5, 2.9, that kind of thing. So it's probably not something I would worry about too much. If it is elevated, I would probably want to check it again to make sure it comes down, having said that. The other ones that I've read about, although it's been a few years since I've really delved into it, procalcitonin, but that's a general biomarker for sepsis. We use it in the ICU, as you know, so that may have some indications. Again, I'm not quite up on that literature.
And in terms of other adjunctive therapies for patients who are being managed non-operatively, so typically we're going to wait 3 to 5 days before we consider intervening. What's the role of nutrition in these patients? Are you starting patients on parenteral nutrition if they're at risk at the time of admission, or do you kind of wait with the hope that they'll resolve within 5 to 7 days, at which point you would just resume them on their enteral nutrition?
Again, patient specific, but there are things that you can use to clue yourself in. The chronic small bowel obstruction patients that come in monthly, several times a year, they tend to be malnourished. So those patients, I would be much more aggressive. I will freely admit we are probably too aggressive with TPN. Take that for what it's worth.
I'm a fan.
Yeah. Okay, good. It's a complicated decision, I suppose, but it's the malnourished patient, the patient that hasn't eaten for probably 4, 5, 6 days, where we don't think it's going to get better the next 2 to 3 days. 7 days, it's kind of like tracheostomy. If you want to get that done by, 7 to 14 days, you probably should do it sooner rather than later. Initiating a diet, or TPN, I guess, in this case, probably a good idea if you in your mind predict that by day 7, you're not going to be having an oral diet.
And so if our patient now, day 3, day 4, day 5, still got their NG tube in, what's your threshold for getting rid of that? And do you sort of wean off the NG tube from low intermittent suction to gravity, or do you clamp it? People seem to have different approaches.
I don't know that there's a right approach. I think our practice has evolved because we hate putting tubes back in for 2 reasons. One, because patients don't want that. And secondly, the patients look at you like you were wrong, man. You failed me. Right? I mean, and we don't want to be wrong.
Right.
So we'll keep it in an extra day just so we're not wrong. Clamp it 4 or 6 hours, check residuals. And if they're within a couple of 100 cc's residuals, pretty comfortable taking the tube out. The other thing, though, you got to make sure you're cognizant of are the ability to protect their airway, because they could still have an ileus or bowel obstruction, I suppose, and still have gastric distension. And if they're an elderly patient, they're certainly at risk for aspiration.
Yeah. On the topic of aspiration, I think one of the things we should really emphasize is if you are going to take a patient to the operating room and they've got an operative bowel obstruction, these patients are at risk for aspiration at the time of induction. And if you've ever witnessed that or had that unfortunate clinical experience, I mean, it can be pretty impressive. If they get that into their airways, they can develop a rip-roaring ARDS, and it really just complicates their entire hospital course.
Yeah, so in all of my studies, there may be one in one of the studies, but on all of our studies, basically, we've never had an aspiration pneumonitis from Gastrografin. And unfortunately, in the last 2 to 3 years, we've had about 3. So 1 a year, not bad, but when it happens, you remember it. And the honest truth there is it was all in octogenarians and older, all 3 of them. So that's kind of where I take a little bit of a pause with the elderly patients. The interesting one, the last patient we had was just a few months ago, unfortunately, but I actually explored the patient because they had a bowel obstruction. Their abdominal exam hadn't worsened, but the patient was intubated on pressors because of the ARDS, and we needed to. Really didn't think she had a strangulation, but I didn't know how else to rule it out. So I laparoscoped her, and it wasn't strangulated. We fixed it, but her ARDS, it got better. You remember those events?
Yeah, you definitely do, for sure. So, unfortunately, a not so uncommon cause for bowel obstruction is malignancy, whether suspected or confirmed. So why don't we shift gears a bit, getting back to etiologies and management strategies. Share with us your approach or thoughts on managing patients with malignant bowel obstruction.
Sure. Obviously, very complicated patients. You have to really consider what's going on, not only with the operative scheme of what you're developing, but what's going on with the patient. Are they on chemotherapy? Are they in hospice? Because you'll get patients on hospice coming into the ER. Is there an appetite for an operation that may or may not be a benefit, considering the potential complications with some of these operations that we're considering? And so I think those things really need to be taken into account before you would ever consider an operation. And that takes, unfortunately, during COVID, telephone calls with a lot of family members because they, at least in our institution, they only get one family member up there.
Same here.
And a lot of these patients tend to be delirious, but not always, of course. And so they can make, good decisions. So that's number one, social situation and really what's going on with their malignancy. Second, though, almost a contraindication in my mind if they have malignant ascites. The wound complications that you'll get are potentially profound. And what you don't want to do is have somebody worse off than they started. And so if you have somebody that you did a laparoscopic exploration or open, whatever you did, even if you relieve the bowel obstruction, everything from that standpoint is great, and they have a wound pouring out acidic fluid and malignancy, you probably didn't do them any favors, and is the reality there. Of course, you need to look at the CT scan to make sure that there are where the targets are. If this is carcinomatosis and there's big masses, a lot of times you're not going to be able to find bypassable segments, but you may not know that until you get into the operating room. I've noticed a trend that's improved, but some surgeons tend to be cowboys, think they can fix anything. Sometimes palliation and peg tube is the best course, because what you're not going to do is extend the patient's life, and they have 3 to 6 months to live. So you really need to think that you can help somebody before you can do an operation. The other thing to think about is Gastrografin challenge. So we do have a paper out there on malignant Gastrografin or malignant bowel obstruction and Gastrografin challenge, and it works and is safe. And the nice thing about it is it gets patients out of the hospital. And these are patients, again, that have months to live and don't want to be in the hospital. They want to be with friends, family, loved ones, wherever that may be. And so you can get them out of the hospital. Now, they may return with a bowel obstruction because you didn't fix necessarily the it's a fixed transition point in masses, generally speaking. But at least you can try to get them tempered by and out of the hospital.
Yeah, I think you bring up some fantastic points, and really starting with that first conversation with our patients and their families to talk about the pros and cons of an operative approach is really so important. Like you mentioned, frailty, especially in elderly patients, is a major issue. And we really should be focusing on quality versus quantity. And if we are going to focus on quantity, it should be less days in hospital, more times at home on hospice or receiving palliation.
And it's never a comfortable conversation because you're meeting these patients in the ER and they don't know you from anybody.
Yeah, I really think that what you just said there deserves to be emphasized. The AAST Critical Care Committee performed a needs assessment to define key research topics in surgical critical care moving forward. Mm-hmm. And the number one identified research question was how to address goals of care in the acute care setting. Like you said, you're meeting these patients and their loved ones for the very first time. We're talking life and death, surgery, no surgery, as well as hospitalization versus home with palliation. And all of these conversations really do require patience, empathy, and understanding of what we can and cannot do surgically. Again, surgery does not and cannot cure all. So with that said, now when it comes to large bowel obstructions in particular for more distal lesions, it seems like in the last decade, there's been a big push for more minimally invasive endoscopic procedures, and they really seem to have found a home in the management of patients with malignant and non-malignant large bowel obstructions. Whereas previously, one might consider getting super aggressive or treating a patient with a distal large bowel obstruction surgically, even just bringing up a stoma. These days, we have the option of colonoscopy with stenting.
Stenting is obviously much less invasive, and it does a couple of things. It maybe allow a patient to limp through and get back home, but also it may allow you to prep things a little bit better if you do want to go to the operating room, if you believe in prep, although that's, I guess, debatable.
How aggressive are your GI endoscopists in getting these stents in for malignant bowel obstructions?
We generally don't even see most of those patients unless they have a complication, because their first line will be stenting. Now, when they perforate, they'll call us or migrate or obstruct or something like that again. But and sometimes they'll even do stents and stents. I've seen that a couple of times, which boggles my mind, but it seems to work.
Yeah, but I do like the concept that you just brought up. Namely, if you can relieve the obstruction and then have your patient prepped, you may be able to perform a one-stage procedure versus being forced to bring up a stoma, which ultimately may be better for our patients in the long run.
Yep.
Well, Dr. Zielinski, I've really enjoyed our conversation today, and thank you for joining us on Rounds. Do you have any final key take-home points or clinical pearls that you feel our listeners should walk away from this episode or this podcast with?
Yeah, I think never forget about strangulation obstructions. Rule those out. I think that's always the number one step, especially for learners earlier on. Make sure that you look for all those signs and read up on what those signs are. The Gastrografin challenge, I think, in my not so humble opinion, has honestly revolutionized the treatment of small bowel obstruction. And it's really the standardization of the management in my mind that has allowed that, because that protocol has really metastasized throughout a lot of the academic centers and allowed us to know what works and what doesn't work. And it's changed over time, but I think it's really been a beneficial thing to the patients.
Well, thanks again, man. I really, really appreciate this, Dr. Zielinski.
You bet. Thank you for having me. It's been a fun time.
Well, that's another episode of Rounds. If you enjoy what you're listening to or you find it somewhat or even very educational, please share it with us in the world. You can find us at iTunes, Spotify, Stitcher, wherever you normally download your podcast from. Please leave us a positive rating as well as a kind comment. Until next time, please stay safe. This pandemic is getting way out of hand. Take care of yourselves, take care of each other, continue reading, and we will talk to you next time. Take care.